Hi everyone, I wanted to make this video to describe how I get large bore access safely and effectively using ultrasound guidance. There have been a number of studies that have demonstrated that using ultrasound decreases the time needed to gain access and also reduces the risk of complications. My talk will focus on the technique that I use to gain access using ultrasound and fluoroscopy. If you want to see more on the data supporting this, there's a great talk by Dr. Sridevi Pita. Please see the link here to view that talk. The way I get access revolves around three basic principles. First, defining the anatomy clearly so you know what you're getting into. The second portion is gaining the access. And the third is confirming that the access you've obtained is where you want to be. Typically, I use my left hand to stabilize the ultrasound probe and my right hand to get the access. Some patients will require some pressure on the probe to push back tissue, but too much pressure will obliterate the femoral vein, making it very difficult to access. While getting large bore access, I often anesthetize the skin generously and also use the needle to check my trajectory toward the artery and anesthetize the artery, as there is some discomfort while putting large bore sheaths in the artery. The angle of entry can be very important, especially when using large bore access. If your angle is too steep, the sheath may kink as soon as the dilator is removed. While dealing with a larger patient, you may need to anticipate going further distal with your needle entry point, as the travel distance under the subcutaneous tissue will be longer, with a goal of entering the artery over the femoral head. The needle tip should be bright on ultrasound. You should not be fooled by movement, as sometimes the needle will move the subcutaneous tissue and you enter at a point in the vessel that you didn't intend. Once you gain blood return through the needle, keep the same amount of tension on the ultrasound probe until you have a wire within the vessel, as changing the tension may move the needle tip. I typically look briefly under fluoroscopy to ensure the needle tip is over the femoral head and that the wire is traveling in the anticipated artery or vein intended. I routinely use femoral angiography if I plan on large bore access, a closure device, or if there's any question that I'm in the right location. One of the great advantages of using a micropuncture technique is that if using the dilator to perform femoral angiography and you're not satisfied, you can minimize the arteriotomy by removing the dilator and trying again in a different location. When performing femoral angiography, please consider pulling the microsheath back 1 to 2 millimeters to ensure that it is not against the wall of the artery, which could lead to dissection during femoral angiography. It goes without saying that the more you do it, the easier it will become. There's good evidence to support using it after 10 times in a row. Your learning curve starts to flatten out a little bit, it becomes easier. And you may consider using it routinely on the radial artery until your tactile feel is such that it's second nature. I wanted to give you a demonstration of my technique that I did it in the cath lab on a transcatheter valve patient. First thing I'm going to show you is how easy it is to get radial access by using ultrasound. This is the radial artery under ultrasound. You can see if I pause it here that there's a bright line underneath the radial artery, that's the radius. And I'm actually having the yellow lines that represent the center of the ultrasound off center a little bit so I can anesthetize around the radial artery without hitting the artery. Although it is often easy to palpate the radial artery and gain access to it, ultrasound can be a very useful tool in increasing your accuracy and decrease the number of passes with the needle. To be accurate and precise in gaining femoral artery access, fluoroscopy is required. Using the skin fold along the inguinal line is an unreliable landmark, especially in larger patients. You can see here the importance of defining the anatomy. There are areas of this artery that have plaque and calcium, and also you can sweep down and make sure you understand and know where the bifurcation is, which is identified here with the arrow. Once I anesthetize the skin, I appreciate where the vein is, which should be easily collapsible. As I said, too much pressure will make entry into the vein difficult. Here I am anesthetizing around the vein. After that, I anesthetize around the artery, and this appears to be a desirable part of the artery to enter. With the needle at about 45 degrees and directed toward the vein, I can see I'm tenting the vein with the needle, and then I advance until I enter the lumen of the vein. Sometimes you need to come back a little bit on the needle if you've gone to the back wall of the vein. And here I'm confirming the tip of the needle is over the femoral head and the wire is in the IVC to the right of the spine. You can see I've left the micro wire in place. This makes it easier to ultrasound the artery while gaining access. As I advance the needle toward the artery, you can see it begin to tent. The needle is not seen on ultrasound until the moment it enters the artery in this case, and it has a very bright tip. This gives you confidence that you've done a single anterior stick and it's in the desired location. And again, use fluoroscopy to ensure that I've entered the artery over the femoral head. I use the inner dilator of the microsheath to perform femoral angiography, especially if I'm going to plan to use large bore access and heparinize to therapeutic levels. Thanks for watching. I hope it was informative and will help you with your ultrasound technique.